Thanks for tuning in to another episode of Watson Clinic Health Talk. I'm your host, Jamie Duvall, a content strategist in the Watson Clinic Marketing Communications and Media Relations Department. Our guest on this episode is Dr. Dominic DiPierro. He's a board-certified podiatric surgeon with an expansive range of expertise in the treatment of foot and ankle injuries and disorders. In this conversation, Dr. DiPierro will discuss the finer points of heel pain, what can cause it, and the non-surgical and minimally invasive surgical solutions to remedy it. Dr. DiPierro treats patients from our Watson Clinic Highlands facility at 2300 East County Road 540A in South Lakeland, and from the Watson Clinic Bartow Building A facility at 2250 Osprey Boulevard, Suite 100 in Bartow. For more information and to schedule an appointment with Dr. DiPierro, call 863-680-7214 or visit watsonclinic.com/DiPierro. That's DiPierro. When you chose a topic for the podcast, you chose to discuss heel pain. And I understand it's because a lot of people come to you with complaints of heel pain, but that can encompass so many different conditions, right?
It's a big topic.
Yeah.
And there's a lot of things certain people think about heel pain or what they hear from their friends that have had it or, and there's a lot of things that can cause it. So just kind of want to talk a little bit about some of the different diagnoses and maybe that'll help some people.
Well, let's get into that. So let's talk about some of the causes of heel pain. Let's start with plantar fasciitis.
Right, plantar fasciitis. Yeah, it's on the top of the list of most common, causes of heel pain. There isn't a lot of accurate data on the percentage of the population that gets affected by this kind of thing. There are numbers out there that say 10% of the Americans, will be affected by this in their life, or we do see a prevalence where more so people in their 40s to 60s, or people with a higher body mass index. So weight does play a factor, into the cause of it sometimes, but mostly it's a biomechanical problem, bodily, mechanical, the movement of it and how it works. So,
and what does it entail? What's damaged when you have that?
Well, it's a good question. Because what the plantar fascia is, it's a really sturdy piece of tissue on the bottom of the foot. It comes from the heel bone and goes all the way and attaches to the base of the toes. And it's like a ligament. It's made of collagen fibers, and it's made to resist tensile strength, stress on it, rather. When the body is moving, it's built to function in a range of motion. And, your muscles turn into tendons that attach to bones and move your bones. And your ligaments support your joints. So the function of this plantar fascia is to help support your arch. So when you have biomechanical dysfunction, whether it's tight muscles or your arch is flattened, some people have a high arch, and that can cause plantar fasciitis for different reasons, but it's biomechanics from the abnormal function and the abnormal range of motion of your foot and your ankle, and then it leads to the abnormal use of the plantar fascia. And over time, it gets degenerated, gets inflamed, and most commonly where it attaches at the heel.
Mm. Yeah. So the dangers of not seeking treatment as soon as you feel discomfort is it will further progress and immobilize you.
It can progress. And I hear a lot of different scenarios, over time, just in practice, in my practice, where, I'm guilty of it too. I'm busy. I have a life. I have family obligations. I've got to work, and things just kind of get put off. Anytime you can get something treated earlier, it's a lot of times easier to treat than more the end stage problems. But, once something gets into a certain number of months and is chronically, repetitively inflamed and painful, the tissue will go through changes, and it becomes something it can be more difficult to treat, or you have to treat in a different way. The newer term is fasciosis instead of fasciitis. Fasciitis is inflammation of the fascia. Fasciosis is referring to a change in the ligament itself where it thickens and kind of scars in and the collagen fibers get separated, and it's not a very vascular tissue, and it may need to be treated differently than just plantar fasciitis, which more commonly can be treated non-surgically. And it can take time to heal, but if you're consistent and you can catch it early enough.
What are the most common treatments for fasciitis?
Oh, that's a good question. Yeah, there's a lot of information on the internet about, wear this, do that. There are a lot of people selling things. A big one is stretching. You'll see everybody says, well, stretch it. Well, that's because your muscles that attach to your heel bone, specifically the Achilles tendon is the biggest tendon in the body, but the lower extremity involves the muscles from the hips down. And there's a cascade of those muscles functioning that will lead to that Achilles tendon pulling abnormally on the back of your heel. It keeps your fascia under tension and is a big reason why people tell you to stretch, because that relieves the tension on the fascia. But there's ways to tape your foot and support the fascia. There's orthotics in your shoes, whether they're custom made or prefabricated. Medications you can we have topical medications you can rub onto your skin to try and transdermally, send the medication to the area of pain and inflammation. There's oral medications and anti-inflammatories. When you get to the doctor, there's injections of corticosteroid, and you have to be careful about that. And plantar fasciitis, a big part of treating it is the history. Patients have a difficulty when they're working on hard surfaces for long periods of time, standing in the same area for long periods of time, sitting for long periods of time. They don't get up much and everything contracts. So they might have other systemic diseases that could lead to heel pain that need to be ruled out. Some things like autoimmune disorders or, especially when there's bilateral, both heels hurting. You have to be inquisitive about, your lower back, because most of the time plantar fasciitis affects one heel. You can have it in both, but you have to make sure, is that pain coming from a problem in your lower back that is neurologic, which can be more common when it comes to having bilateral heel pain in the bottom of the foot. So it's important to talk to the doctor about those kinds of things, because it will change the treatment plan, especially if you're doing all these things at home, like icing it. And, there was something became popular years ago about, icing, where you put a frozen, or you get a water bottle, freeze it, and then you rub your foot on it. Now, I don't really like that one, because if you think about it, you're just rubbing your heel that hurts on a block of ice. So, yeah. But to get things therapeutic, you ice water in a bag, 10 minutes on, you get it numb. That's the point of the ice. And then you can massage it. It's less painful. Then you go 10 minutes off and massaging, and then you put 10 minutes back on with the ice. So you can do all these things, rub your heel on a spiky massage ball, any of these modalities, but the doctor can help you if you need professional physical therapy, if you need the custom inserts, when do I get a shot and why or how, and is it plantar fascia or not? There are a lot of other things that we can talk about too, we'll get to, that are not the cause of the heel pain in that area. So.
Yeah. Now the injections, is there an average length of time that those injections work? Do they wear off after a certain amount of time?
It's really not something you can predict. Why? There are external variables that are beyond your control. The medication, in my practice, I use ultrasound a lot, especially in this, so I can put the medication right where the inflammation is in the fascia. And it's a targeted thing. It can be very accurate, and the steroids can be powerful. Now, if we go back to doing the same things that caused it in the first place, whether it was a certain pair of shoes, or you're still standing on those hard surfaces, or you go back to you're not changing any activity, you're not doing any modifications to your activities or any of the things that may have contributed to it in the first place, you're going to have a higher chance of that injection medication not lasting. So you have to be consistent, and it can take months. it can take months.
Okay. So a lot of these options that you've talked about ease discomfort, they restore a sense of mobility and range of motion. Does it take surgery to fix it, to reverse it altogether, or?
Typically, it's non-surgical treatment for plantar fasciitis. There are times where it's necessary. There are some newer modalities out there that over the past, couple decades that have become more in vogue and are minimally invasive techniques to try and stimulate, healing in the fascia that's degenerated or chronically inflamed and try and get it to heal. There are some cases where if the non-surgical fails and you may need to, have your plantar fascia surgery to actually cure the problem.
So that's not typical.
It's not as common as in my practice, and in my training and colleagues that I talk to, and it seems to be the consensus in the literature as well. There's one thing about it that's interesting for a lot of people throughout the generations that I see in my practice. They say, well, I have heel spurs. And you go, okay. And because what we learn when we study this is that there can be a spur on the bottom of the heel sometimes when you take the x-ray and you see it. What we know is that more times than not, it is not the cause of the problem. And that it's actually the soft tissues around it. The spurs can form from the attachments to the heel bone pulling on it. I mean, bone grows in response to stress and in the direction of stress. So if there's something like this happening over time chronically, these spurs can form, but very seldom are they the actual cause of the problem. That's another reason why I like ultrasound in my practice, because when I take a look at this, I can see, is the fascia inflamed? Is the spur actually inside the fascia itself? Is there impingement on the muscle? Is there pain being from swelling in the fat pad surrounding the spur itself? So, is there cystic change? There are a lot of things you can look at to target, your treatment plan accurately and really help the patient, because there's a lot of things you need to rule out. So that's a good modality in seeing whether or not the spur is actually causing you part of your pain, outside of being able to see it with the imaging like that, the ultrasound. There's MRIs too, but they're more expensive. And, the ultrasound has the advantage of being a dynamic image. I can move your muscles around and see how things are working at the same time. And so it's something to clear up a little bit as well, because, well, I had spur down there and it's just, this is never going away and stuff. No, if we can rule that out, we know that you're getting your pain from somewhere else, and then we can accurately treat it.
So among the other causes, is something like Achilles tendonitis an issue as well that could cause heel pain?
It's a big topic. Yeah. Achilles tendon, it's a really common one too. And going back to when we mentioned the bilateral heel pain, I've seen this more commonly where this is where you're going to have pain in the back of the heel. Plantar fasciitis, you'll have pain more on the bottom of the heel. But the Achilles tendon inserts on the back of the heel, and everybody that has had this problem knows right where this is painful. And it's a big structure, but it's usually where it attaches in the back of the heel. And it can be associated with having kind of like a palpable lump back there, a really prominent bone, or again, if you have tight musculature and it's constantly causing tension on the back of the heel, you will get irritation of that tendon where it inserts on the bone. The other anatomy that's in that area you need to rule out are bursitis. There are bursal sacs which protect bones, and they can get inflamed. They're usually in between structures, like in between a tendon and a bone, so that when things rub, the bursa is protective. There's one in between the skin and the heel bone itself back there. So when those parts are inflamed, that can cause pain in a different way. Maybe you're just having pain when you're resting your heel on the ground, or maybe it's from the back of your shoe rubbing on it constantly, and it's not your Achilles tendon, it's just your bursa being inflamed. But it's on the back of that really prominent area, that bump back there. And those things are treated differently. Other causes of it can be spurring in the back of the heel. Now this is different when a spurring happens in the back of the heel than on the bottom. On the bottom, we talked about it being with plantar fascia, how it doesn't really cause the problem very often. It can really be associated with causing the tendon problems and the pain in the back of the heel, though. So, it can cause calcifications in the insertion of the Achilles tendon itself. It can cause Achilles tendon to tear because it's got a jagged piece of bone stuck through the tendon. And over time, with continued use, and the tendon will change, and you can get chronic tearing that will change the treatment plan. So, for these kinds of things, the non-surgical treatments you get over-the-counter heel lifts to put in your sandals or on them so that you're decreasing your pull on the back of the tendon. A lot of these are aimed toward doing that. Rocker shoes, that helps to decrease the tension when your heel strike and when you're going through mid-stance and kind of push off with your gait cycle, because you're trying to reduce the repetitive biomechanics that really cause inflammation. Systemic problems that you may have, medical issues that cause inflammation, like we talked about some of the autoimmune diseases, rheumatoid arthritis, psoriatics, lupus, other things that cause connective tissue problems. So you have to rule those things out. People also have traumas, and they may or may not even know it. In plantar fascia, I didn't talk about it as much, but one of the causes of heel pain in the plantar fascia area is rupture, which, when you look at the literature, it's usually associated with a certain way the foot mechanics happens, and you may or may not even feel it. It might feel like a little pop or a little tear down there, but nothing high energy traumatic or anything. And then the Achilles tendon rupture, of course, that can cause, heel pain. We all know, people have heard stories or know some athlete or somebody who had that. And that usually gets treated more immediately, but the people have had previous surgeries is another thing you have to examine. So it's important to go to the doctor for those kinds of things. If you had surgery in an area or a trauma in an area, and you need to find out what is causing you to have heel pain. Injections in the tendon of corticosteroid, and we don't typically do that because if you don't want to degenerate the tendon. And that's why it's important to delineate, hey, is it bursitis or is it tendinitis or is it the bone? And another great thing for the Achilles tendinitis problems I didn't mention is professional physical therapy. I've seen people, whether they have a large body mass index or not, do really well with that for that problem. If it's truly just the Achilles tendinitis, when you rule out all the other things. And although it may take consistency and time to treat that with professional physical therapy, I've seen a lot of people get better and avoid surgical intervention for that problem too. So, yeah.
And you, I would imagine, routinely refer and work in concert with our physical therapy department and sports medicine department. You guys work hand in hand quite frequently, don't you?
Yes, and I having been up there myself, I think it's a great environment, and they really have some modalities that I haven't seen in other physical therapy places that I've have been in throughout my career. So it's just a great environment. The people are very knowledgeable, willing to help, and I have had patients tell me the same.
You mentioned conditions like bursitis or psoriatic arthritis and that sort of thing, rheumatoid arthritis that can cause foot and heel pain. Another common condition that many people suffer from is diabetes, and that has implications in the foot as well, doesn't it?
Data about the percentage of people with diabetes that end up with a heel pain or a problem, more the data is around neuropathy, foot ulcerations, things like that. But one of the things that is important about diabetes is that there's a process that can happen if your sugar is uncontrolled, and it's called glycosylation. So the end product of sugar and being broken down, it's going to bind to certain proteins and lipids, and there's collagen involved, and all these tendons and ligaments and everything that's in the heel, they're made of that. So what happens over time with glycosylation, what we see is that there's laxity to these tissues when they should be stronger. There can be, these chronic changes that make it more susceptible to these chronic problems not going away. Also to foot and ankle, problems that we see that go along with diabetes become worse because the function of these tendons is abnormal as opposed to like a non-glycosylated tissue. So it's very important to, mention that to your doctor when you have diabetes too. And that way you can go through how controlled you are, and are you not having these changes in your, tissues, and what's the likelihood of that? I mean, it really has a lot to do with your hemoglobin A1C control. I mean, we do see, and if you read different literature, you can find different numbers for anything, but we do see that typically A1C above 8, this long-term sugar control number, we really start seeing a lot more of the foot and ankle problems. So if you're diabetic and you're having some types of A1C and you're pretty well controlled, but you start noticing, 7.5, I'm getting closer to that. And we want to be between 5 and 6, but on the A1C number. But if you know that you're starting to get up there and you're getting near 8, man, you call your doctor, find out what's going on, get your medicines changed, or however you need to change your diet and get that number back down to 6. Because once you start having these changes, they're very difficult to reverse. There have been plenty of diabetic patients that I've treated with heel problems and heel pain, and they've done just fine. You just want to give yourself the best platform you can to heal these things. So that's why getting that number down, and it's a very difficult thing to do consistently over time. So, I think it's important to have the whole team on your side, and so you can get help with these things. So they have some neurologic problems, whether it's neuropathy or not, that needs to be sorted out with the exam. And if you have heel pain, you're diabetic, you go to a doctor. It comes back also to another heel pain issue that can be feeling like plantar fasciitis or be misdiagnosed as plantar fasciitis. It's nerve entrapments, and there are certain nerves in the heel and around it in the ankle that can become compressed for certain reasons, and you end up having heel pain. And it's not getting better with any of the plantar fascia treatments, and it's just there and it's nagging, and then it starts to limit your ability to do your job or to stand or to walk or sleep. Sometimes presents right in the same area as the plantar fascia, but there's certain things you have to look at on exam and make sure, is it heel pain or is it not? One of them that is a more common one is called Baxter's neuritis, right? So this guy, Dr. Donald Baxter, was an orthopedic surgeon in 1984. He was the first one to actually describe this at that time. There's a nerve that is both motor and sensory. It helps to make a little muscle in your foot move your pinky toe, and also provides sensation to the side of your heel. And you'll have more pain around the rim of your heel. You'll have more pain when you're walking, or, longer you're on your feet. Whereas plantar fasciitis is more, I get out of bed in the morning and that thing is hurting. Whoa, your first step is a doozy, and then it kind of tapers off as you kind of keep walking. And then, plantar fascia can turn into where it hurts all the time. That's more another thing too with heel pain can be neurologic. And that nerve, that Baxter's nerve, is part of a branch of a nerve that comes from the nerves in your spine, your lower spine, and the sciatic nerve branches, they go all the way down your leg into your feet and fingers, just like a tree branch. There can be an area in your ankle that's entrapped, causing the heel pain. You can have a nerve in the back of your leg that is causing the pain in the back of your heel when it's misdiagnosed as Achilles tendonitis. That's another thing that is challenging for people with diabetes too, and I should say people if they have any type of neuropathy, and more commonly people have neuropathy with diabetes.
Let me ask you a little bit about the nerve therapies, because thinking throughout your career since you've been a practicing podiatrist, is the area of nerve damage repair, nerve regeneration, that sort of thing, is that the most exciting advance that you've seen in the podiatry field in recent years?
Well, exciting. It's hard to say. Exciting. I get excited.
Did I use the wrong adjective?
Anytime you get somebody figured out, I'm excited. Like, all right, God, good. I helped this person. Thank you, God.
Oh yeah.
Right. So, because some of this stuff is complex though, and taking something that can be a long-term or a very difficult problem for a lot of podiatrists to help to figure out, and then finding out that, you figure out how a nerve functions or is dysfunctioning, and then you can fix it. And so that there is excitement in that, anytime that you can do things better, like I mentioned earlier about the plantar fascia, there are some in vogue treatments that have come out. Some people do a shockwave therapy that's been around for a good, 20, 30 years, and you get variable results. There's no real data for any of these treatments, but they're based on being minimally invasive to you. There's a radio frequency ablation, type thing where they'll try and you stick a needle into where your nerve or your fascia is, or there's cryo surgical techniques where they take a needle and try and freeze that area so that you can stop the pain. And they're all mostly aimed at trying to get neovascularization into that scarred up area to get it to start to heal. There's another one called recently it's called TenJet. It's where they take a needle and put it into your thickened up fascia, or and stream saline through it to try and generate that inflammatory response to get the vessels to grow in there and heal. We used to have another one that isn't used as commonly anymore, called the topaz procedure, when we were doing surgery and we kind of poke holes in it, and then it was done through the skin and trying to get all the same thing to happen. The one thing about it, though, is you're causing an inflammatory response every time you do something invasive or especially surgical. The one that we're finding that is kind of exciting to me is recently that is helping to reduce that is the use of umbilical cord to inject on these chronically inflamed areas. And why? From what I'm learning about it and the use of it in my practice, and for different reasons, whether it's wounds or traumas or rebuilding tissue or stopping inflammation or plantar fasciitis or tendon problems or even neurologic problems, is that these problems I just discussed can have chronic inflammation, and that leads to a model of healing where there's increased collagen deposition in these tissues, and that leads to increased scar formation, and that's not a very functional tissue. Whereas the use of the umbilical cord and the way it works is actually decreases the expression of those inflammatory markers. So the stem cells that are being recruited to that area for healing are actually native to that tissue, and you get regeneration of the native tissue versus increased scarring. And with that regeneration, one of the added phenomenons that can be seen with the use of it is a decrease in pain. So that's another exciting thing, because it's something that is not a surgical thing that can really make a difference in a patient's treatment plan when they've got a chronic problem that's not getting any better. To me, some of those things are exciting.
I wanted to ask you a general question for everyone out there, whether you've experienced foot pain or you've had any issues with your feet or not. What are some tips that you have to keep your feet healthy and mobile and vital?
Number one, inspect them. And if you can't, find someone who can. I mean, there are a lot of people out there, they can't bend down, they can't see, their hands are, unable to be, because they have ailments. And so use a mirror, do what you can. That's one thing. And then keep up with your shoes. If they should have been thrown out 3 months ago, get a new pair.
And what you're looking for is, I would imagine, strong heel support, what you're looking for in a shoe.
Yeah, and it's dependent on some different scenarios. I mean, if you have more of a flat foot, you may need to have an arch support in your shoe, because the flat foot will cause heel pain, and you need to address that. So how do you do that? Well, we do that with the arch supports and or the shoes. And then when you have a higher arch foot, that may be more of a problem during your gait cycle with your shock absorption. So you may need a shoe that's more geared toward that. And, here's another tip. Spend some time putting these shoes on before you buy them. Try if you order on the internet and walk around in them around your house for a while. You'll know if they're right for you or not. If they hurt, send them back. You're the boss. You know what feels good and what doesn't. if you are the type of person that sits a lot, or if you're the type of person you have a really physically demanding job, don't go 5 months, a year, or 2 years before you actually start stretching your body at night once a day. It's too easy to get on YouTube now and find a 10-minute thing that fits your needs, that, you know, you're busy mom or dad or whatever. And you can go in the other room for 10 minutes and at the end of the day and just put the thing on and just do the routine with the video. Even if you're getting it a few times a week, I mean, doing something for 10 minutes a day to maintain 6 days a week or 5 days a week is much better than doing something for 40 minutes once a week or once a couple of weeks. You know, you're going to get more out of it consistently, and that can help with a lot of these ailments that we talked about that cause heel pain. So there's another little tip there, and just don't ignore it. You know, you're worth it. You're high functioning. You gotta get taken care of so you can keep functioning for everyone around you. You know, you can't take care of yourself, then you're not going to be any help to anybody else.
Exactly.
So,
I think that's good advice.
Yeah.
Thank you for coming by and talking to us today, Dr. DiPierro. Thank you.
Thank you for having me.
That does it for another episode of Watson Clinic Health Talk. Appointments with Dr. DiPierro may be scheduled by calling 863-680-7214 or by visiting watsonclinic.com/DiPierro. And while you're on our site, visit watsonclinic.com/podcast, where you can subscribe to our show for free and make sure you never miss an episode. Till next time, thanks for listening.